One, please start. We are live.
Okay. Hello, good evening, everyone. It's a great pleasure to welcome you all of this very exciting scientific webinar, Lung Cancer Connect. It's a great pleasure to invite Dr. Uh, Rajeshwar Singh. He's a Director Medical Oncology. He's a working in Director Medical Oncology, Paras Hospital in Panchkula. To give welcome and introduction note, it's over to you, Dr. Rajeshwar, sir.
Okay, thank you very much. Thank you, Surbi. So basically today we have got together here to discuss about important cancer, that is a lung cancer. Now in lung cancer, it was very difficult disease before. Almost all patients were dying a decade back. Then there is a lot of excitement about the targeted therapies as well as you see immunotherapy has come in this. Though the excitement is a lot about this cancer, but still our patient, majority of the patient, in fact 90% of the patient, we can't give these treatments. There are many hurdles of diagnosis, hurdles of tissue, financial hurdles and all. But still, as the time passes, what we could not do, even a single patient couple of years back, now more and more patients are coming into this sphere of this modern management of lung cancer based on a particular driver mutation. And now we are seeing those results which were never even heard of a decade back. So not coming in between, and the first discussion will be on the role of BRAF mutation in non-small cell lung cancer. For that, I invite Dr. Priyanshu. He's a consultant medical oncologist from the Shalby Hospital, and of course, many hospitals visiting in Tri-City. He did his MD from MAMC and his DM from AIMS. So I request Dr. Priyanshu to proceed with his presentation.
Good evening, sir. Thank you, sir, for giving me this opportunity. And as rightly said that, the treatment paradigm of lung cancer has changed tremendously in the last decade or so. And I think one of the challenges which sir stated was the testing of various mutations. Earlier, a lot of mutations were not tested because we didn't have much of targeted agents. But nowadays, even uncommon like MET, BRAF, or even now upcoming is the KRAS inhibitors are there in the market. So the first and the foremost thing is to test. And these days, NGS platforms are available. And so I will be concentrating today on personalized therapy to further improve outcomes in patients with BRAF mutated metastatic non-small cell lung cancer. So this is the disclaimer. And the objectives today is to understand the role of BRAF in metastatic non-small cell lung cancer, to gain awareness of BRAF testing method and the diagnosis of BRAF positive non-small cell lung cancer, to review the clinical data for dabrafenib, that with the trade name of Refilar, and dramatinib, that is Mexil, in advanced non-small cell lung cancer. So the introduction to BRAF. We all know about the EGFR ligand, surface ligand, and it has two main downstream pathways. One is the PIK3CA AKT pathway, which includes NF, kappa beta, and mTOR. The other is the KRAS, BRAF, MEK, MAP kinase pathway. So BRAF mutation are commonly found in melanoma, around 50 to 60%, 10% of colon, 30 to 50% of thyroid, especially the anaplastic variants, and 2 to 4% in non-small cell lung cancer. So the MAP kinase pathway regulates cell signaling from transmembrane growth factor receptor, leading to cell proliferation. The oncogenic mutation in the MAP kinase pathway, including BRAF kinase mutation, have been reported in a number of human cancers, including NSCLC. The BRAF mutation resulted in constitutive BRAF activation and uncontrolled signaling via the MAP kinase pathway. And when I talk about BRAF mutation in non-small cell lung cancer, they occur in 1 to 4% of all NSCLC adenocarcinomas. So they are typically exclusive of other mutations like KRAS, EGFR, or ALK. And but in contrast to other oncogenic drivers in NSCLC, key patient characteristics and indicators for BRAF mutated NSCLC have not been well characterized. So they do not, the BRAF mutation do not appear to correlate strongly with age, sex, stage of diagnosis, or smoking status. However, there are some studies which suggest that patients with BRAF mutation are more likely to be female or have a history of smoking. Among the BRAF mutations, the BRAF V600E is the most common mutation, occurring in around 50 to 70% of all cases. And it is caused by point mutation in the BRAF kinase domain at position 600. A valine is changed to glutamic acid, that is V2E. Again, we know that most common is BRAF V600E, but there are other mutations also. The diversity of BRAF mutation has important implications. Different strategies may be required for the targeted treatment of NSCLC bearing V600 or non-V600 and or inactivating BRAF mutations. So in a large retrospective analysis of 1046 NSCLC tumor, BRAF mutation were present in 4.9% of adenocarcinomas, and out of these 56.7% were V600E and 43.3% were non-V600 mutations. So there are different kind of non-V6E mutations which are mentioned here, like K601N, D594G, and others. So coming to the fact that patients with BRAF V600E mutations have shorter median DFS and OS than patients without V600E mutation. This was a 2011 JCO publication. It was a retrospective analysis of around 1,000 patients, out of which patient with patient who had V600 BRAF mutation, they had a inferior disease-free survival as well as overall survival compared to the patient who had a wild type metastatic non-small cell lung cancer. Similarly, another study from 2013 also showed that the outcomes were poorer in patient who had a BRAF V600E, and the patient who had received the first-line platinum-based chemotherapy, the overall response rates, as we can see, were significantly lower in patient with BRAF mutation, 29% versus 48% in BRAF wild. And the median PFS was also shorter, 4.1 versus 6.7. The median overall survival was again shorter, 10.8 versus 15.9 months. Approximately 1/3 of the patients with BRAF mutations remain untreated. Almost 1/3 of the patient with BRAF V600 non-small cell lung cancer received best supportive care as the first line, and 57% received best supportive care second line. The most common therapy was doublet chemotherapy, as shown in the French registry, received in almost more than half of the patients. And in patients with driver mutation, targeted therapy can help patients live longer. So patient who identifies the mutation driver but did not receive targeted therapy lived 1 year shorter than those who actually received this therapy. These are the Western data. Probably in India, we have even a much more percentage of patients who cannot receive targeted therapy for BRAF. So these are the guidelines, which is summary of current treatment guidelines for advanced metastatic disease. We all know in driver negative patients, we can use first line immunotherapy or a doublet chemotherapy plus minus bevacizumab. And on progression, you can use a single agent immunotherapy or a doublet chemotherapy in patient who have PS 0 to 2. And in patient PS 3 and 4, the best supportive care is the treatment of choice. So now coming to the testing, the historical approach encourages serial testing with companion diagnostic. We used to test, reflex testing by EGFR. Then if it is negative, then go on for further testing. But nowadays, the current treatment paradigm favors broad molecular profiling for all patients. In non-squamous NSCLC, broad molecular profiling using NGS-based testing is preferred to include mutation in EGFR, ALK, ROS1, BRAF, PDL1, HER2, RET, MET, or KRAS. So the guidelines, both ESMO as well as NCCN, suggest that a broader molecular profiling to identify the rare driver mutations is preferred these days. And broad molecular profiling can be achieved by companion diagnostic NGS technologies. So upfront BRAF testing is essential for patients with advanced NSCLC because BRAF does not appear to correlate with any clinical risk factors like age, sex, or smoking history. So, you cannot select patients just on the basis of any specific clinical factor. The BRAF positive NSCLC may be more aggressive than lung cancer with other mutations or histologies. And as we have seen that they may not be as responsive to first-line chemotherapy as the BRAF wild patients. Targeting BRAF mutation has demonstrated clinical efficacy in patients with BRAF positive NSCLC. So a broad molecular profiling using NGS-based testing can help identify more actionable drivers such as BRAF V600 at the diagnosis itself. Now coming to the clinical data of dabrafenib plus trametinib. So dabrafenib and trametinib are, they target different kinases in the MAP kinase pathway. So dabrafenib targets it's a potent selective inhibitor of RAF kinase, particularly the BRAF and especially the BRAF V600E and 600K. And trametinib is a reversible, highly selective inhibitor of MEK1 and MEK2 kinase activity. So they target two different pathways, upstream and downstream. It has been approved in India by DCGI. Dabrafenib in combination with trametinib is indicated for the treatment of adult patients with advanced NSCLC with a BRAF V600 mutation. So now what is the rationale for combination of dabrafenib and trametinib? So the combination therapy that targets multiple portions of the MAP kinase pathway have been developed to overcome resistance to BRAF inhibitors monotherapy in non-small cell lung cancer and as well as melanoma. Compared with BRAF inhibition alone, the BRAF and MEK combination has been shown to, synergistically inhibit the MAP kinase pathways in BRAF V600 positive cell lines and to delay resistance to BRAF inhibitors in animal models. It inhibits cancer growth more effectively than dabrafenib alone in clinical trials, leading to the approval of dabrafenib plus trametinib for the treatment of BRAF V600 positive advanced melanoma. So as we can see here in this diagram that we can inhibit multiple levels of this MAP kinase pathway, and if we target BRAF alone, then the RAS pathway can be activated through the other pathways, that is ARAF and CRAF. But if we use a MEK inhibitor, so we can have combined blockade, which would be more effective. So this was a phase 2 study of dabrafenib plus trametinib in BRAF positive NSCLC. It was a multi-cohort, non-randomized, open-label phase 2 study, which included patients with stage 4 BRAF V600E positive NSCLC with a ECOG PS of 0 to 2, and no prior treatment with a BRAF or MEK inhibitors was allowed. And patients with symptomatic, non-stable, or more than 1 centimeter brain metastasis were excluded. So the patients were randomized into 3 cohorts, cohort A, B, and C. Cohort A included patients who had previous treatment with 1 or more platinum-based chemotherapy, and the patients were treated with dabrafenib alone at a dose of 150 milligram twice a day. Cohort B also included patients who had previous treatment with 1 to 3 lines of therapy. But in this cohort, dabrafenib was used in the same dose along with trametinib 2 milligram OD. Type C, cohort C included patients who were treatment naive and were given the combination of dabrafenib plus trametinib. So the primary endpoint was investigator-assessed overall response rate as confirmed by RECIST, and independent review committee was also used. And the secondary endpoints were progression-free survival, duration of response, overall survival, safety, and population pharmacokinetics.
Dr. Puranshu, just slightly faster, 2 minutes.
Yes, sir. Yes, sir, sure, sir. So these were the patient profile. If you see, 2/3 of the patients were current or former smokers. Nearly all patients had adenocarcinoma histology, and almost half of the patients were in second line and beyond. In the cohort B, again, almost all patients had adenocarcinoma, three quarters were current or former smokers, and 1/3 of the patient had 2 or more lines of chemotherapy. Cohort C also, most of the patients were adenocarcinoma histology and current or former smokers. So if we see here, if the efficacy, if we can see the overall response rate in cohort A with dabrafenib alone was, the overall response rate was 33%, disease control rate 58%, and a median PFS of 5.5 months. In cohort B, in patient who had a combination of dabrafenib plus trametinib, overall response rate 36%, disease control rate 45%, and 43% as assessed by investigator and independent review. And the duration of response was, median duration of response was 9 months in both these assessments. So if we look at the waterfall plot, the majority of the patient in cohort B experienced tumor shrinkage, and overall response rate was 63%. In patient, 50% of the responses were ongoing at the time of data cutoff, and the median duration of response as assessed by investigator and independent was both 9 months each. The median PFS was 9.7 months as assessed by investigator and 8.6 months as by independent review. The 6 months PFS percentage was 65%, which is quite impressive. In cohort C, the overall response rate was 23% in both the investigator and independent review, while the disease control rate was almost 27% and 26%. The median duration of response was 10.4 and 15.2 months. Again, we can see that majority of the patient experienced tumor shrinkage. So the duration of response was 10.4 and 15.2 months. We have seen earlier. The median PFS was 10.9 months in the investigator assessed arm, and independent review showed a 14.6 months median PFS in cohort C, and 6 months PFS was an impressive 72%. So this is a summary of the efficacy. Now coming to the the safety profile, the most common adverse effects were pyrexia, which is quite common with this combination, and then you had asthenia, hyperkeratosis, decreased appetite, cough, fatigue, etc. Nearly all patients in cohort B experienced any form of side effects, and almost 49% had grade 3 or 4 adverse effects, but the rate of discontinuation was less, around 14%. Compare it with the previous, where we have dabrafenib monotherapy, the grade 3 and 4 side effects were less than 5%. So the combination had more side effects, but it also has more efficacy. And again, pyrexia was the most common, but only 2 to 3%, 2% had a grade 3 pyrexia. Now, if we see again in the next cohort, if we see again pyrexia, most common adverse effect, 64% of the patient, but the discontinuation rate was still pretty low. So how to manage pyrexia? We have to definitely rule out other causes like infection, and you have to interrupt treatment with dabrafenib if the patient temperature is more than equal to 38.5 degrees, and we can continue trametinib at the same dose. Initiate antipyretics such as ibuprofen or acetaminophen or paracetamol.
Request Phyllis.
And in patients who had considered oral corticosteroids in those instances where antipyretics are insufficient. So the management of pyrexia include what we have just discussed in the first event, but if the fever was associated with dehydration, hypotension, or renal insufficiency, then we have to reduce the dose of dabrafenib by 1 dose level. In case of second event, you have to start corticosteroid, prednisone 10 mg for 5 days. In subsequent level, we have to reduce the dose to -1 level. So the dose reduction involves a starting dose of 150 mg BD for dabrafenib. First dose reduction 100 mg twice a day. Second is 50 mg twice a day. And the trametinib 2 mg starting, 1.5 mg in the first dose, and 1 mg in the second dose reduction. So to summarize, the safety profile of dabrafenib plus trametinib was manageable and similar to previously reported melanoma studies. The most common adverse effects were pyrexia, GI-related toxicity, and skin reactions. And pyrexia was the most common adverse effect observed across all the cohorts. So this is all we have in my talk, and thank you, and over to the organizers.
Thank you, Dr. Priyanshu. Lovely presentation. I think cardiomyopathy is also one of the side effect, and I had one patient with cardiomyopathy, and surprising immunotherapy works best of all the targeted wherever mutations is there. So I had to treat with the immunotherapy, and patient survived for 1 year. Thank you very much.
Thank you,
And
sir.
now we proceed to the master class of today, that is optimal management of EGFR mutation non-small cell lung cancer. And it will be given by none other than Dr. Navneet Singh, who's professor of pulmonology at PGI Chandigarh. He's brought quite a number of laurel to Tri-City for being a member, not only all over India, but of course at representative of India in ASCO also. So not wasting much of time, I request Dr. Navneet to proceed with this lecture, please.
Thank you, sir, for the kind introduction. Let me start by sharing the screen. One second. Okay, right. So I think it's visible, right? And I'm
Yeah.
all right. Okay. So the topic assigned is optimal management of EGFR mutated metastatic NSCLC. So, I mean, like all other topics in lung cancer, I'm sure you can talk about this for hours and have special sessions for EGFR positive alone. But I will try to cover to the best of my ability in the next 20 minutes or so. So, right. So this is how an EGFR positive report looks like. You are all very familiar with this. We have been seeing these reports for a decade now, and it doesn't really matter whether it's a biopsy specimen or a cytology with a cell block specimen. You can have EGFR testing just as well done. And for the treating clinician, it's just as good to see a L858R as it is an exon 19 deletion. But of course, there's a lot of debate about that. So just a few background facts. EGFR mutations are the commonest druggable targets in metastatic non-small cell lung cancer. The frequency of EGFR mutations in metastatic NSCLC, essentially, which is lung adenocarcinoma, is approximately 25 to 30% in India. And we all know that treatment with an EGFR targeted drug is more effective and better tolerated than standard platinum doublet chemotherapy when you have these common sensitizing EGFR mutations, that's exon 19 deletions and L858R. And now you have several EGFR TKIs available, first generation, second generation, third generation. You also have multiple combinations of first generation TKIs with other targeted drugs and with chemotherapy. So I was obviously privileged to be chairing this ASCO guideline expert panel. We have come out with this update very, very recently. In fact, the last issue of JCO, this has come in. And just to imagine that the previous update came only last year. That is the pace at which NSCLC management, especially metastatic disease, is changing. So basically, there are twin publications now for with driver alterations and without driver alterations. And in 2017, there was just one update for NSCLC, which got split into two in 2020 and 21. And now we in 22, we have this update. And there is another one on the way, which should appear perhaps by the end of the year. So if you were to look at the algorithm for this, and this is treatment naive patients with EGFR mutations, you can see that if you have sensitizing mutations, which are L858R or the exon 19 deletions, you have multiple options. Most of these are monotherapy with either osimertinib or the second generation drugs, dacomitinib, afatinib, first generation drugs, erlotinib and gefitinib. But you also have the combinations, for example, gefitinib with pemetrexed chemotherapy, and the data for this came from none other than the Tata Memorial Group. And you also have erlotinib with ramucirumab of bevacizumab. If you have the uncommon mutations, then the data is much more strong for afatinib rather than any drug, but osimertinib can also be used, and therefore you can see that the degree of evidence is different. This is moderate recommendation for afatinib and a weak one for osimertinib, as opposed to for classical mutations where the strongest recommendation has been for osimertinib. Important to know that for PS3 patients, there's a weak recommendation for a monotherapy with any of these drugs, but we all know in real life setting that PS3 is a significant proportion. Now, if you talk of patients who have received an EGFR drug before, this looks simpler. If you've been treated with a drug other than osimertinib and you are able to demonstrate the resistance mutation T790M, the obvious choice is osimertinib. But if that is not there, then it goes on to a standard treatment based upon non-driver mutation guidelines. And for uncommon mutations, it directly goes to this pathway. It's important to emphasize that liquid biopsy is very helpful for patients who have been treated with first or second generation EGFR TKIs and have had progression, because if you pick up the T790M, you really don't need more testing. And this was a poster which we presented last year at the ESMO Congress. Our pickup rate was approximately 1 out of 3 for EGFR positive, and with a decent concordance. So, but there are still a lot of areas of uncertainty. And one question is, does the most effective treatment option vary according to the type of EGFR mutation? Second question is, which strategy, sequencing of treatment options versus best treatment option first, which is the most effective and cost effective? And thirdly, can available evidence from phase 3 trials be applied to the real world setting, especially for groups which are excluded, which is ECOG performance status 2, 3, and 4, comorbid illnesses, and untreated brain mets. So coming first to this question, based upon the type of mutation. And now this is the distribution of mutations in our setting. It is largely similar to what you see elsewhere in the country or even across the world. Exon 19 deletions being the commonest, 2 out of 3. L858R point mutation on exon 21 is the next most common, 1 out of 4. And all of the others are a small percentage. And it's important to know that exon 20 insertions is actually third most common after exon 19 deletions and L858R. Also, you can find T790M at baseline in approximately 5% of patients. And dual mutations are seen in a 3 to 4% at baseline. Now, we know that exon 19 deletions are prognostically the most favorable EGFR mutation type. And there is also a tendency for the second generation drug afatinib and the third generation drug osimertinib to demonstrate greater efficacy for this mutation as compared to others. Now, the L858R exon 21 mutation, you may want to consider a different or a more aggressive treatment plan, example, chemotherapy with gefitinib, or erlotinib with either ramucirumab or bevacizumab, or dacometinib itself. So prognostically, exon 19 deletions are the best, followed by L858R. Now for uncommon mutations, which is basically L861Q, S768I, and G719X, afatinib is the TKI of choice, and there is really no other drug which comes even close to that. And as I said, exon 20 insertion mutations are the third most common. And as we speak, we have seen that amivantamab and mobocertinib have now received approval for this type of EGFR mutations. You could use them upfront, or you could use them after they have received the standard therapy. The second question is, which strategy is more effective and cost effective, sequencing of treatment options or best treatment option first? What is the basis for this? So the best treatment option first strategy is basically based on the presumption that patients may not get second line treatment on progression, and that the most effective treatment given earlier achieves greater progression-free survival and perhaps even overall survival, compared to reserving this for patients who have progressed on lesser effective treatment options in the first line. On the other hand, the sequencing of treatment strategy advocates using these drugs with increasing efficacy when you develop resistance or progression with the first line treatment, and thereby you retain the ability to offer a targeted drug at multiple timelines in the patient's illness. And so let's look at how these you could implement them. So one strategy obviously is you use the first or second generation TKIs. You have the progression-free survival or PFS1. Then you look for T790M. If it is positive, the drug of choice is obviously osimertinib. If it is negative or on progression on osimertinib, the treatment of choice would be pemetrexed platinum followed by docetaxel. Then the other approach is what has been followed in FLAURA, which is using osimertinib upfront. And then at progression, you could look for CS79S mutation as one of the mechanisms of resistance. If that is present, you could use a first generation TKI. But on progression on that, or if that is not there, then you again go on to the same pathway of using pemetrexed platinum and then docetaxel on progression. Now, the third approach is using the first or the second generation TKI with a pemetrexed platinum. As of now, this data is limited to gefitinib with pemetrexed carboplatin. There is not any other data for any other combination. On progression, theoretically, you could look for T790M and see if it is present. I have asked this data to Kumar and Vanita, but they have not yet come up with this. And so we really don't know whether the prevalence of T790M, when you use this combination, is it the same as when you use monotherapy or not? But assuming that you have T790M at this point of time, you will obviously go on to osimertinib. If that is not there, or if there is progression on osimertinib, then you will go on to docetaxel. And this is what has been tested in FLAURA 2, where you're combining osimertinib with pemetrexed platinum. And obviously, you would expect a greater PFS1. We don't have the results yet. I assume they would be presented at ASCO next year, but I really don't know. Astra guys would know. And on progression, well, you would go on to docetaxel. And obviously, we have not factored in using the VEGF inhibitors along with typically with erlotinib or other resistance mechanisms in this diagrammatic representation. So let's look at what the numbers say. Well, if you use FLAURA, which is the third generation TKI upfront, you get a PFS of 19 months vis-a-vis 10 months with a hazard ratio of 0.46, an overall survival of almost 39 months vis-a-vis 32 months with the first generation TKI. If you were to use the sequential approach of which was followed in AURA3, basically used gefitinib or erlotinib upfront and then followed up with osimertinib on progression, then the PFS with osimertinib is again approximately 10 months versus 4.4 months with pemetrexed platinum, hazard ratio again 0.3. Overall survival is around 27 months here with this approach. This is lesser than what you would see with FLAURA. However, if you look at the Archer 1050, which was using afatinib, which is using dacometinib upfront and then following it up with osimertinib, the OS here is very close to what you saw with FLAURA, approximately 34 months, and better than what you got with the first generation drug, which was gefitinib. And the hazard ratio for overall survival was 0.76 here, almost identical to what was seen with FLAURA. For LUX-Lung 7, in which you use afatinib followed by, compared to gefitinib, the difference wasn't really as impressive. So again, trying to put everything into context and also trying to factor in the combination of erlotinib with ramucirumab, you can see that there are multiple ways of treating EGFR positive patients. You can use multiple approaches and still reach an overall survival which crosses 3 years, and even a chemo-free survival of approximately 2 years or so. This one of these, obviously last one is not strictly chemo-free, it is just to give you a comparison, but all the 4 above are sort of chemo-free regimens. The bottom line about all of this is that if you use sequential treatment, a substantial proportion of patients can be effectively chemotherapy free for prolonged time periods. And just to illustrate that this is not only theory, we have seen it practically. We published this a couple of years back in which we had patients who reached 10 years survival with metastatic disease, primarily based upon using different treatment regimens at different time points, doing multiple testing, including liquid biopsies, rebiopsy. And for the patient as well as for the treating clinician, that is something very satisfying. This is another such patient in whom we did at multiple time points, some of initial ones being negative, and then the follow-up liquid biopsy showing T790M positive. In between, we even had a MET amplification, gave a small trial of crizotinib plus afatinib. If you were to talk of the mechanisms of acquired resistance to first and second generation TKIs, as we know that T790M is approximately 40 to 55%. And the other mechanisms are to a lesser degree present. Small cell transformation is something which is described in 10%. We have seen in few patients. And just to give you an example, this was a 67-year-old lady, no smoking history, L858R exon 21 mutation detected at baseline, metastatic disease, obviously, given gefitinib first line therapy. Now, progression-free survival here was 31 months, as opposed to what is described of 9 to 13 months. At progression, T790M was negative in liquid biopsy, and a rebiopsy was done, which showed small cell transformation. And so she received etoposide carboplatin, but had progression in the period of 4 months, and a liquid biopsy then showed a T790M positive, and a rebiopsy confirmed that. And so this is very unusual. We've just published that in, it's been published by my pathology colleagues. Lastly, can you use available evidence from phase 3 trials to real world settings, and especially for groups which are excluded from clinical trials? So let's first talk about the underrepresented groups, which are ECOG performance status 2 to 4. Now, for performance status 2, I think they should receive EGFR TKI in the standard dosing in the absence of any other comorbid illness. They may even be considered for chemotherapy plus gefitinib with an appropriate dose reduction for the chemotherapy drugs. For PS3, a trial of EGFR TKIs in dosage which is likely to balance efficacy with toxicity is warranted. And you can often start with every alternate dosing and gradually increase to 36-hour administrations, and finally to even once daily if tolerance has been ensured and the response or efficacy is along the expected lines. PS4, it's entirely a clinical discretion. You have to discuss pros and cons with the caregivers, and then decide whether you want to offer treatment with EGFR TKI or not. Untreated brain mets. Now, so if the patients are asymptomatic or even very mildly symptomatic, there are a limited number of brain metastases, preferably less than 5. They are subcentimetric, and there is no edema or compressive features on MRI. You can start preferably with third generation TKI, have a close watch, and reassess in 4 to 6 weeks. All of these criteria have to be met. On the other hand, if the patient is asymptomatic but has multiple mets, or these are more than 1 centimeter but less than 3 centimeters, or if there is presence of edema or compressive features, SRS can be considered if it is technically feasible, along with a short course of steroids and the EGFR directed therapy. Again, a third generation drug is preferred because of its brain penetration. On the other hand, if you have symptomatic large brain mets, significant edema or compressive features, then it is steroids plus an EGFR drug and whole brain radiation. But one has to factor in the cost when we are living in low and middle income countries. And as you can see, gefitinib, erlotinib, and now afatinib continue to be the cheapest drugs available simply because they are available as generics. On the other hand, dacometinib and osimertinib do not have any generic manufacturer, and therefore their cost is often prohibitive. Osimertinib continue to be the most expensive drug. Just to give illustrations and how we can treat. So the first is a 46-year-old male with exon 19 deletions, no comorbidities, no brain metastasis, has a significant symptom burden, is willing for chemotherapy and cannot afford the high-end molecules. So suggested treatment would be gefitinib and pemetrexed carboplatin. Next case, 78-year-old lady with an L858R, multiple comorbidities, no brain metastasis, some symptom burden, not willing for chemotherapy, and also cannot afford the innovator molecules. So the choice would be either Gefitinib or Erlotinib. Third case is 61-year-old male, L861Q exon 21 mutation, which is an uncommon mutation, has a single comorbidities, no brain metastasis, has some moderate symptom burden, again, not willing for chemotherapy and not affording other things. So I would give generic Afatinib. 57-year-old lady with an exon 19 deletion and a T790M at baseline. And this was an actual case. We have had this in 2 cases in demonstrable both in blood and tissue. No comorbidities, presence of brain metastasis, a moderate symptom burden, is willing for chemotherapy, but is also no issues with affordability. And in this case, I would put the patient on Osimertinib. If you were to change just one characteristic in these patients, for example, if the affordability in the first patient was there and the symptom burden was minimal, I would give Osimertinib. Similarly, if the second patient, there was only one comorbidity and affordability was there, I would give either Dacomitinib or the combination of Erlotinib plus Ramucirumab. The third patient, if there was brain metastasis, but affordability was able to afford, I would give Afatinib along with SBRT. And in the fourth patient, if there was no brain metastasis and could not afford Osimertinib, I would put her on Gefitinib plus Pemetrexed carboplatin. So there are multiple ways in which you can treat this thing. Now, what about non-metastatic disease? So there is emerging evidence for using EGFR TKIs. For early stage resected NSCLC, they should receive EGFR TKIs, preferably after completion of the standard platinum-based adjuvant chemotherapy, which is indicated for stages 2 to 3A. Stage 1B, for whom adjuvant chemotherapy is not indicated, may receive EGFR TKI as the sole adjuvant treatment. And the data for this scenario is currently strongest for Osimertinib based on the ADAURA trial. Because other trials have largely compared EGFR TKI to chemotherapy and not use an approach of using EGFR TKI subsequent to chemotherapy. Now, for this scenario, early stage resected NSCLC, which is basically a curative intent treatment, chemotherapy should be administered wherever indicated, and the TKIs should follow that. Stage 3 unresectable NSCLC, which harbor an EGFR mutations, there are no recommendations yet for maintenance EGFR TKI after chemoradiation. But there is a big word of caution that these patients should not be given maintenance durvalumab if you are aware of an EGFR mutation, no matter how high the PD-L1, because they do not benefit from durvalumab. And in fact, there is a school of thought that actually EGFR mutations may be given as maintenance. So to summarize, there are multiple treatment options for EGFR mutated metastatic NSCLC. You can use monotherapy with any of the generations of TKIs, first, second, third. You can combine TKIs with chemotherapy or with VEGF inhibitors, and this is largely Gefitinib, Pemetrexed carboplatin, or Erlotinib, Bevacizumab, or Ramucirumab. Now, important determinants of treatment choice are obviously cost of therapy, age, comorbid illnesses, whether you have brain mets or not, what is the extent of symptoms, what are the patient preferences and wishes, and the anticipated toxicity profile. But all of this discussion would be redundant if every eligible patient is not tested for EGFR and ALK. So the most crucial part in all of that is that all patients with metastatic lung adenocarcinoma and other non-squamous histologies should be tested for common oncogenic drivers, which is EGFR mutations and ALK rearrangements, and they should receive the appropriate targeted therapy if eligible, because what makes a difference in survival is testing for an oncogenic driver alteration and giving the appropriate targeted therapy. It really does not matter if the driver is there and it hasn't been tested, or if it is there and the treatment has not been offered. So with that, I'd like to conclude. Thank you, and I'll be happy to take any question.
Thank you very much. Do you recommend for stage 3 lung cancer to do EGFR all by NGS, all this testing? Because generally it is not being done till now.
So I am not advocating necessarily doing NGS, but EGFR should be tested for all stages of lung cancer, whether it is early stage, unresectable, locally advanced, or metastatic. And I mean, we have had patients, we had one patient recently who was EGFR positive, in whom the initial suspicion was that she has metastatic disease, but we were not very sure. So we actually put her on the chemotherapy and Gefitinib, reassessed after 3 cycles, and were able to show that there was actually no metastatic disease. She's had a curative intent surgical resection and has currently been shifted to adjuvant Afatinib simply because the patient could not afford adjuvant Osimertinib.
And this one case you presented, that transformation from non-small cell to small cell, and again back to this. Any explanation? How will you give that?
Yes, so small cell transformation usually is stand-alone, which means you will not have the T790M. But what happened in this case was that obviously as resistance occurred, there was a clone of small cell which were there. And at the start of it, the small cells were the dominant clone. Once we gave chemotherapy, that clone got wiped off. And the T790M, which was probably harboring in the background, but was not detectable because it was being dominated by small cell, that became dominant. And that is why the T790M was detectable. It's not that the small cell transformed back into a T790M. It is just that there are multiple clones, but the small cell was the dominant clone at the time of the first progression.
Can I ask one question?
Yeah, please.
So, Dr. Navneet, in your experience, have you seen rapid transformation just at the start of the treatment? You have biopsied and found exon 19 del, and patient didn't respond even in the first month, and rapidly progressed and succumbed. And probably found to be small cell. So do you have any experience of any such rapid transformations to small cell, or could it be coincidentally both the clones coexisting?
So we don't have rapid transformations. All of the patients who have developed have been on the after an expected progression-free survival with first generation drugs. But if you're having rapid progression, the best way would be to do an NGS, and in most situations you would either find a TP53 or other mutations which are indicative of small cell transformations.
Okay, and the in line with the same thing, how much credence do you give to TP53 mutation in your management of EGFR mutated patients at present?
As of now, there is no recommendation to treat them separately, but if you have detected that at baseline, I think you would have to have a close watch for early progression. You may even be tempted to treat these patients with the combination of either chemo with Gefitinib or Erlotinib with a VEGF inhibitor, simply because monotherapy may not be sufficient for them. But there are no definitive recommendations as of now to stratify treatment based upon the coexisting mutations in NGS, which are typically non-driver.
Okay, thank you.
So thank you, Dr. Navneet. That was a master class in a very short span. You covered I think everything has been covered in this short span. Thank you very much. That was a wonderful presentation.
Thank you.
And now we proceed on to the next presentation, a role of bevacizumab in non-small cell lung cancer. And it will be given by Dr. Jatin Sareen. Dr. Jatin is HOD and Director of Medical Oncology at IV Hospital. Yeah, he's, I think oldest, not in the age wise, but he started, in fact, oncology in Tri-City. There were first 3 people who really started oncology from a nascent time, and now it has grown to a big this thing. Every hospital has got oncologist, but that time only few were there, and he is a stalwart in Tri-City. So I'll request Dr. Jatin to proceed with his presentation.
So can I share my screen?
Yes, sir, you can.
Thank you. So thank you, Rajeshwar sir, for giving me the opportunity. And it was a wonderful lecture. As every time, he just mesmerizes us with the wonderful inputs in topics in which we have heard so many times, but again, the doubts keep on creeping. So why are we discussing anti-VEGF treatment in NSCLC now, in this era of immunotherapy, in this era of targeted therapy? Because we are still a country in which most of our patients cannot bear the expense of immunotherapy, and they don't have access to immunotherapy. And even with immunotherapy, anti-VEGF has its role. We'll come to see about it. Well, what is the role, how anti-VEGF came into non-small cell lung cancer? So there were 2 phase 3 trials in the first line setting, and they were E4599 and AVAIL, in which both of them had significant ORR and PFS benefit, but OS benefit was seen mainly in E4599. AVAIL didn't show much of OS benefit as against the comparator arm. And then we will see that there is an efficacy finding substantiated in a large non-randomized observational study, that is SAIL. And the last part of my lecture will cover up that what is the emerging role of bevacizumab in NSCLC. So E4599, these were the these were the arms. It was a randomized studies, previously untreated stage 3 B to 4 non-squamous non-small cell lung cancer. And it was rather all kinds of lung cancer, not really non-squamous, because non-squamous was separately assessed in this. And 6 cycles of carbopacli with addition of bevacizumab was compared with standard arm of carbopacli. And bevacizumab arm was given a maintenance Bevaci 15 mg per kg till progression. The primary endpoint of this study was overall survival. The secondary endpoints were overall response rate and progression-free survival. And the stratification factors were measurable disease, prior radiation therapy, prior weight loss, and of less than 5% in disease stage. So this trial significantly showed improvement in the OS. The median was 12.3 months in the experimental arm against the standard arm of 10.3 months, with a hazard ratio of 0.79, as you can see in these graphs. And in the adenocarcinoma subgroup, it was actually 14.2 months. In the pure adenocarcinoma subgroup, it was 14.2 with a hazard ratio of 0.69. So specifically for adenocarcinoma, bevacizumab addition to chemotherapy really helped. PFS was also prolonged compared to chemotherapy alone. The overall response rate was significantly better, about 35% compared to 15% in the chemotherapy arm. Then was this AVAIL study, in which bevacizumab in both 15 mg per kg and then half dosages, 7.5 mg per kg, were compared with the comparator arm, which was chemotherapy alone, but this time the chemotherapy backbone was cisplatin gemcitabine, and it was a trial in which both previously untreated stage 3B4 or recurrent non-squamous. So it was in non-squamous in which this chemotherapy arm was used. And in all these arms, the maintenance, in the bevacizumab containing arms, the maintenance of bevacizumab was given in the similar dosages as it was given along with chemotherapy. The stratification factor were performance status, region, sex, and disease stage. So, as you can see, the PFS, median PFS were not much of a difference, just a slightly better PFS in the 7.5 mg per kg or lesser dose Bevacizumab arm versus 15 mg per kg Bevacizumab arm. The response rates were also definitely increased, but as you can see, the survival difference was not significant at all, and the hazard ratios, as you can see, just 0.92, and there was hardly any survival difference between the three arms. But PFS, yes, they said that they were statistically significant, and so was response rate. So this was the non-randomized observational studies in which practically in routine oncology practice, the previously untreated stage 3B4 recurrent or recurrent non-squamous NSCLC, in which Bevacizumab either 7.5 or 15 mg per kg with the standard chemotherapy was used, and bevacizumab was given as a maintenance till progressive disease. And it was found in this particular study that the overall median OS was 14.6, which was nearly similar to what we have seen in previous studies. And it was found that there was 18.8 months of median OS achieved in responding patients treated to progression. So patients in which Bevacizumab was not stopped due to any reason and they will continue to receive Bevacizumab, they had even better median OS. And so we can all see these are the consistent median OS of Bevacizumab combination with chemotherapy, and they all range between 12 to 14 or 15 months. The same first line Bevacizumab difference, as you can see in AVAIL, the median OS difference is hardly existent. But so then came AVAPearl study, which was more similar to since pemetrexed came into practice, first line induction with Bev cis Pem, and followed by randomization. Actually, randomization was done after that. And there was one arm of Bevacizumab maintenance, another arm was Bevacizumab plus pemetrexed maintenance. So this was the AVAPearl trial. So as you can see in the Bevacizumab plus PEM combination maintenance arm, the PFS was unprecedented. That was 10.2 months as against the Bevacizumab arm, which was 6.6 months. And again, from randomization, Bev plus PEM arm had 7.4 months and Bev alone was 3.7 months. And this was the PFS subgroup analysis, and most of the subgroup, whether age, performance status, never or chronic current smokers, adenocarcinoma, and stable disease prior to randomization or CRPR prior to randomization, all of these subgroups benefited in Bevacizumab PEM maintenance, though the this was the overall survival. The hazard ratio was 0.75. So the important thing is that the adverse effects were obviously grade 3-5 hematological adverse effects were more in combination arm, and non-hematological adverse effects were nearly similar. And so the only difference was hematological side effects were definitely increased in. So conclusions were that Avapearl trial met its primary endpoint. First line cis-pem-bev followed by continuation PEM plus bev achieved a PFS benefit of unprecedented magnitude in an unselected non-small cell lung cancer. And both regimens were well tolerated, but adverse events occurred more frequently in the Bevacizumab arm, with some differences due to toxicity commonly attributed to chemotherapy. And OS data favors continuation maintenance with BevPEM, and overall Avapearl strongly favors the use of BevPEM as continuation maintenance in non-small cell lung cancer. Then came Point Break study, in which you compared carbopacli with carbopimtrixate. The bevacizumab used was 15 mg per kg. The primary endpoint was OS, and in this it was shown that in both the arms there was hardly any difference between the both. There was hardly any difference between the overall survival, and same goes with PFS. Adverse effects were definitely more in PEM carb-bev arm because the maintenance had more of the drug in the form of PEM-bev, while Paclicarb has only Bevacizumab maintenance. So you had to give more supportive care in Bev-PEM arm. So these were the conclusions in which they compared to most frequently used Bevacizumab continuation, original carbo-Pacli-bev versus carbo-PEM-bev. And both combinations were administered for 4 cycles followed by maintenance. Where there was no significant difference in survival, and toxicity, while slightly different between the arms, did not seem to be statistically different. So these were the guidelines. This I'm talking about 20. This is 2012 paper. Even in 2016, Bevacizumab was part of category 1 recommendation in non-squamous cell lung cancer. So what about the Asian patients? Asian patients fared equally well with Bevacizumab. As you can see, the median OS was even better, 18.9 months, and median PFS was 8.3 months. And overall response rates were also consistent with the overall population. So it can be used in Asian patients very well. So, and this was recommended by NCCN and ESMO at that time. So what came in the era of targeted therapy and immunotherapy? So this was the trial in which this was the phase 2 trial in which erlotinib plus Bevacizumab was compared with erlotinib alone as a first-line treatment for advanced EGFR mutation positive non-squamous NSCLC, and this was J025567 study. This was Japanese study, and these were the randomization. The activating EGFR mutations were taken, exon 19 and 21 mutation, and there were no brain metastasis. This is the important thing to be taken into consideration. And the stratification factors were sex, smoking status, clinical stage, and EGFR mutation type. Primary endpoint of this study was PFS, secondary was OS and response, quality of life, safety. And in this study, the updated PFS was significantly better, hazard ratio of 0.52 was there. So, and but look at the overall survival, erlotinib versus erlotinib bev. There was hardly any difference between the overall survival, and hazard ratio was 0.81. So summary was, it was a prospective randomized phase 2 trial to evaluate PFS. Median OS as long as 4 years was observed in both arms. No significant OS improvement was there. No clear difference between the subgroups, whether you take exon 19 or ALET5 ATR. And for further evaluation of erlotinib combination, there was another trial which was conducted. It was a phase 3 study, and that is NEJ 026. So this was again erlotinib combination with bevacizumab, and this was a phase 3 study. In this bevacizumab, the interesting part was on progression of this arm, there was chemotherapy given. On progression of erlotinib alone arm with chemotherapy, bevacizumab was added. So this was the interesting part. And in this study, asymptomatic CNS metastases were allowed. So the primary endpoint was PFS by independent review, that was 16.9 versus 13.3 months. Yes, it was significant. Hazard ratio was 0.60. Objective tumor response rate, hardly any difference. You can see the waterfall. They seem to be mirror images, Bevacizumab versus Erlo. And as far as the adverse events are concerned, definitely more of hypotension, more of proteinuria, more of hemorrhage, excluding the pulmonary hemorrhage in bevacizumab containing arm was there. So the results or interpretation of this trial was, the result of this trial showed that bevacizumab plus erlotinib improves PFS compared with erlotinib with the EGFR positive and SCLC and future studies. And so this was the conclusion based on this particular study. The overall survival estimates came for this study later on, and they were also showing there was hardly any difference between the overall survival, whether you use erlotinib bev or erlotinib alone. So there was a meta-analysis published last year in which the efficacy and safety of bevacizumab containing regimes with EGFR TKIs in advanced non-small cell lung cancer was published. The conclusion of that paper was that of that particular meta-analysis was that bevacizumab combined with EGFR significantly improves PFS and ORR in patients with advanced NSCLC bearing EGFR mutation, but there is no substantial difference in OS. And there was an increase in risk of serious adverse events. Then came immunotherapy with a bang. What was the rationale of combining immunotherapy with anti-VEGF? So it was found that bevacizumab inhibits VEGF-mediated suppression of dendritic cell maturation, enabling efficient priming and activation of T cell responses. So the complementary effect. So bevacizumab also normalized tumor vasculature, resulting in increased infiltration of T cells. These were all hypotheses. Bevacizumab decreases the activity of myeloid-derived suppressor cells and T regulatory cells. That means it helps in reprogramming the tumor microenvironment, making it more immune sensitive. And chemotherapy along with bevacizumab leads to more cell death, which releases tumor antigens, so increases leading to more active this thing tumor. So IM power 150. This was the study, and this was the study design. And this was a patient with stage 4 recurrent metastatic non-squamous NSCLC with in this carbopacli was combined with atezo in one arm. In the second arm, it was atezo, carbopacli, and bevacizumab, and the third arm or arm C was carbopacli and bevacizumab alone. The main contention was between the two arms, arm B and arm C, whether you can do away with bevacizumab or does addition of atezolizumab led to any significant difference. The maintenance of these three arms were dependent on the kind of immune agent used. So it was atezo-bev combination in maintenance in arm B, bevacizumab alone in arm C, and atezo alone in arm D. The primary endpoints or co-primary endpoints, I would say, was in PFS in intent to treat wild type, T factor high wild type, and OS in intent to treat wild type. So these were the co-primary endpoints, and there were numerous secondary endpoints. We won't go into the detail. And all these three arms were matched as far as the performance status is concerned, as far as the gender of patient is concerned, as far as the number of smokers and non-smokers were concerned, as far as the liver metastasis. And the interesting part in this was there were some EGFR mutation positive patients also, and they were also equally distributed between these three arms. There were also ALK rearranged patient in this particular trial, and high T effector gene signature expression, which is more conducive to action of immunotherapy, were also equally distributed. There was also equal distribution among the extent of PD-L1 expression. This was according to SP142. So TC3 or IC3 was there in around 20% in each, and TC2 out of 3 was in 30%, and TC0, I mean, without any expression of PD-L1, were there in around 50%. So these were the all arms, and this was the, and I had already described before that we are basically looking at arm B and arm C. So arm B was atezo, Bev plus carbo, and it was compared with Bev plus carbo, and PFS in intent to treat wild type population was 8.3 versus 6.8, and the hazard ratio was 0.59. So if you take immunotherapy along with carbopac bev, yes, definitely the PFS was improved in all subgroups, whether it was PD-L1 expressing strongly or expressing weakly or expressing not expressing, or T. So all these subgroups were benefited, though the subgroups having less of PD-L1 expression, less of T factor, or low gene expression of T factor, the hazard ratios were not so good. But most of these were having a positive results. ABCP, as you can say. I'll use the short form. And about the interim OS also, the median OS was with ABCP was 19.2 months versus 14.71, the hazard ratio of 0.78. Again, if we see the forest plot, the interesting part in this forest plot was this EGFR ALK mutation with ABCP. The hazard ratio, you can see 0.54 as compared to BCP, and intent to treat wild type, the hazard ratio 0.78. So this was an interesting thing. The other interesting thing was the liver metastasis, wild type liver metastasis, ABCP versus BCP, the hazard ratio 0.54 versus the ones with no liver metastasis, it was 0.83. So these two bad subgroups, I would say, I mean, bad when they have, sorry, for these, it was both kind of patient, mainly failing TKI therapy was there, and liver metastasis, which is usually a bad subgroup in lung cancer. So they were benefited with the combination arm. According to PD-L1 status, these were the various hazard ratio. Obviously, with TC3 and IC3, the hazard ratio were best. With liver metastasis, you can see the median OS difference 13.2, and with the EGFR or ALK aberration not reached versus 17.5. So wonderful OS recorded without TKI usage. And this was the again the response rates in all this thing. So I just want to highlight in EGFR positive after EGFR TKI. At that time, third generation TKI, obviously now the third generation TKIs are available. But suppose you fail even third generation TKI, can this be an option? So EGFR mutation, ALK rearrangement. So there were 124 patients with EGFR mutation, and 91 had sensitizing EGFR mutation. And out of these 91, 78 were treated with prior TKI therapy. The sensitizing mutations were exon 19 deletion and L858R. So you can see the difference in the Kaplan-Meier curves, and the hazard ratio is 0.59. And similar is the OS benefit in arm B versus arm C. While if we compare arm A versus C, the hazard ratio was 1. So there was no benefit. So addition of immunotherapy really benefited in sensitizing EGFR mutation in combination with chemotherapy and bevacizumab. Overall response rates were also significant increase from 42% to 71% if atezo was added to bevacizumab and carbopaclitaxel. Obviously, the side effect profile would entail more number of side effects, but grade 5 side effects were nearly the same, not much of a significant side effect profile. Even grade 3-4 side effects were nearly similar in all 3 arms. Serious adverse effects were also similar. So that is the strange part, that in all 3 arms, the serious adverse events, there was not much of a difference as far as the quality of life is concerned. And but adverse events leading to discontinuation of treatment was maximum in atezo-bev carbopaclitaxel arm. And this was the immune-related adverse events, obviously more in atezo containing arms compared to bevacizumab containing arms. So the summary was, this was a phase 3 multi-center international randomized open label 3-arm trial. And it was the first chemoimmunotherapy combination to demonstrate meaningful OS in EGFR mutation positive patients and patients with liver metastasis. And atezo plus ABCP nearly doubled PFS benefit at 12 months with it delivered a statistically significant OS benefit versus Bev plus Carbopac alone. As you can see, ABCP versus Bev Carbo plus Pacli. The response rates were also higher, 56% versus 40%. So thank you, and open to any question.
Thank you, Dr. Sachin. You made an exhaustive effort to, bring out positive point of bevacizumab and indication. Now, I have a patient, he has been given Keytruda, Pacli Carbo first line, Pemetrexed, Carboplatin second line, and now will you give gemcitabine cisplatin plus Bev or not?
No. Why this patient in third line? Is he strong enough to receive?
Probably 3 weekly didn't tolerate Pemetrexed plus Bev.
And there was a maintenance also given for Pemetrexed.
Oh, Pemetrexed maintenance given.
Pemetrexed, so Bev was not used in that.
Not used.
So I would see the tolerance profile, but usually in the third line, I won't go for double agent. Usually I won't because I've seen people not tolerating, but if the patient is tolerating, you can start off with. But GEMS, if it is adenocarcinoma, I would be slightly not in favor of giving GEM, maybe a Winelbin or something else.
He's already received Pemetrexed and Pacli Carbo dosage. So,
You can go.
oh yeah.
Can go if he tolerates it. But I think platins going on for such a long time, I am slightly skeptical about the tolerance issue. That's all. Otherwise, if he's tolerating, you can go for it.
Okay, fair enough. Thank you very much. That was exhaustive lecture. In fact, half an hour has gone in and very nicely presented. And I think many points have been cleared by you. Thank you very much, Dr. Jatin. And now we move on to the next topic that.
So now I would like to invite Dr. Rajeshwar sir for a talk, and this session sponsored by AstraZeneca sir.
Can you start my? You have a slides are there, or should I share?
So you can share your slides, sir.
Okay. Now I'll be talking on turning the tides for stage 3 non-small cell lung cancer towards the curative intent. So we all know this data that the problem is that in India the numbers are quite high and the deaths are also very high. If you see the ratio between incident death, roughly about 91%. And lung cancer being, of course, in males the second most common and fourth in both male and female. So if you see the burden of cancer in this 35%, they constitute the loco-regional disease. And of course, the majority are still distance metastasis of 44%. But 35% are locally advanced, in which we can do something definitely more than what it is being done. Now, as far as stage 3 lung cancer is there, we have a multidisciplinary team. We have to have all the main specialists in oncology, because we have to see for pulmonary function test, bronchoscopy may be required, PET-CT definitely required, and brain MRI is also required to rule out stage 4 disease. And of course, the mediastinal nodes are important. So till now, the standard of care has been stage 3 non-small cell cancer. Chemoradiation has found to be beneficial as compared to sequence chemotherapy. So this is how this is a logarithm how we have to start with loco-regional. I mean, how we have to diagnose. What we want is that we have to take out unresectable N2 disease. This is very important. Whatever way we do, whether we have to do media scanoscopy or all the investigation, we have to see that if they are resectable or they are found in surgery, then probably multimodality treatment, neoadjuvant treatment, and surgical is important. But if it is unresectable and when non-surgical treatment is there, this is the thing we are dealing with today. So basically, we want to do curative intent because it is not a metastatic treatment. So we try to give concurrent radiotherapy with chemotherapy, Paclitaxel carbo combination, and where we have reached. Now, we have tried concurrent regimes. Many of these regimes are there. We have seen that who are older like me, that we have tried all sort of combination chemotherapies, and we have tried in sequential regime also. And what we have reached as a median OS of roughly about 14 to 15 months. Apart from that, we have not reached anything in this. Now, as far as consolidation is concerned, after giving a concurrent chemo, at least some consolidation therapies, there are multiple trials, docetaxel, cisplatin, and etoposide, all sort of combination, gemcitabine we have tried. And the hazards are not very encouraging, except for gefitinib, probably it was EGFR mutated case. So what we have, we are trying for curative treatment in stage 3, but 5-year overall survival has been very dismal. It is 15 to 25%. So more we have to do in this because it is a very rapidly progressing disease, and prognosis is not very good what we have achieved. And probably this is a case for 95% of our patients. Now immunotherapy immuno-oncology has come in this, and it really improves the survival. Those to whom we are able to give, we are finding that the results are very, very encouraging. Now, what does a tumor, whenever there is a tumor, there is a expression of PD-L1 upregulation is there. Now, once the PD-L1 upregulation is there, it prevents, it inhibits immune cell, and T cells are unable to recognize this cancer cell as foreign. They because of immune suppression, they think they are their own cells only, so do not react against the cancer cell. But if we block this PD-L1 by PD-L1 blocker like durvalumab, and there is a restoration of T cell function, and it can lead to systemic anti-tumor response. So for this PACIFIC study design, this is not a new design, but we have to revisit this trial again and again as the number of years have passed, and we are having more and more data of this trial. Basically, stage 3 disease, advanced, unresectable, who had received definite platinum-based CCRT, at least 2 cycles, 18 years and older, PS1 and 2, and basically divided. This immunotherapy is to be given within 42 days post CCRT with durvalumab 10 milligram per kg every 15 days for up to 12 months. 2:1 randomized was done, and the co-primary endpoint was PFS by blinded independent center review and OS, which was the primary endpoint, and secondary endpoint was ORR, duration of response, safety, and tolerability. So if you see this PACIFIC study, the patient characteristics in both the arms were almost balanced, whether it is age, whether sex and sex is there, race is there, even Asian were quite a number of this patient, 25%. And apart from stage 3A and 3B were mainly included, and PS1 was mainly included in this. Similarly, EGFR positive were also 6% and 5%. They were equally balanced. PDL expression, smoking history, squamous and non-squamous, they were both balanced. Similarly, the amount of radiotherapy which was given at prior chemotherapy, this I should tell you about induction chemotherapy was there in 25% in both the arms. And as far as CR, PR are concerned, they're also well matched in both the. So now we have initial result was 36 months. Now we have an updated 5-year overall survival within the intent to treat population. If you see this curve, till 36 months, the median was not reached, but now it is median is about 40. If you see that OS is in 42% as compared to the other arm, which was 33%, with a hazard ratio of 0.72, which is very, very good at 5 years. Mind you, we are talking about lung cancer. 5 years getting 42% survival was not heard of, and no other drug gives, especially in stage 3 lung cancer, this sort of survival advantage. So this is the first and only approved IO to demonstrate a 42% OS at 5 years. If we go to the updated PFS, which was done by the blinded independent center review with an intent to treat population, so it is 33% versus the 19% with a hazard of 0.55. This is absolutely very, very significant. Such things were never seen in lung cancer in last 1 decade, especially curable cancer, stage 3 lung cancer. And this was 33.1% benefit at 5 years. So we have seen the data for 2 years, we have seen data for 3 years, 4 years, and now we have 5 years. If you see the overall survival hazard, it is consistent 0.68, 0.69, 0.71, and 0.72. So 5-year data demonstrate a continued benefit of the Pacific regimen. So if we see the subgroup analysis, it benefit all the subgroup, whether less than 65, more than 65, male, female, smoker, stage A, B. Of course, squamous or non-squamous, or what type of chemotherapy was given and what responses. Like we have, Dr. Navneet was talking about the EGFR mutated status. So this is only one place where their responses were less. But apart from that, all the subgroups were benefiting by this. Similarly, in PFS also, all subgroup are benefiting apart from probably the EGFR status group. So there are no guidelines for this. We have to, till we get the firm guidelines, I think we have to treat all the patients irrespective of EGFR status with the Pacific regime. Now, if we see the pattern of disease progression in intent to treat population, the progression was 64% in placebo, whereas only 45% in case of durvalumab. And if we go into subpopulation, those who had a progression, intrathoracic progression was 80% in durvalumab, which was lesser in case of placebo. Why this is important? Since the majority of progression were intrathoracic, they can be again retreated. They can be again retreated by various modalities. So if we see the pattern of progression, the time to intrathoracic progression, so that too is 25 months, median time was 25 in durvalumab as compared to 9.2 months. So, the median was coming quite early at 9 months here in placebo arm, whereas median has come to about 25 months here. So much time is patient is without a progression because of this regimen. So as far as subsequent treatment after discontinuation of durvalumab, it was 54% in placebo arm and 41% in case of durvalumab, and chemotherapy was the main, which was both in both durvalumab and placebo. The numbers were much less in case of durvalumab as compared to the placebo. So, what were the best objective response subsequent to first after this progression on this regimen? So there is a data is not there. Some CRPR have been reported, but if you see here that missing data of 44%, because this was not part of the trial, and subsequently what treatment patient gave and what responses were there, there is very difficult to interpret, because both in durvalumab 44.3% data was not there, and placebo also 35.8% data was not present. As far as safety is concerned, we know we are concerned about pneumonitis post radiotherapy in this, and if you see that some grade of pneumonitis is there, higher 33% as compared to 25%, but the more issue is that the grade 3 and grade 4. Grade 3 and grade 4 are not different in this. Here the discontinuation is important and aggressive treatment is required. They are both in both the same groups. And based on how much time from radiation pneumonitis do occur after radiation, this is in less than 14 days if we have started the treatment. Now, basically, in this trial, treatment was to be started till 42 days. So if less than, we are also concerned at times that should we start early, wait for 15 days, wait for 1 month. So whether we start less than 14 days or we start more than 14 days, there is not much difference between the two arms. Just slight differences there, not much. But if we are only concerned with grade 3 and 4, and that is not much difference between the two, whether you started less than 14 days or more than 14 days. So you can start any time after giving CCRT. There is though we remain concerned about pneumonitis because of some injury which has occurred because of radiation pneumonitis, which is complicated by the pneumonitis of immunotherapy, but that is not seen in this trial. So this is a trial regimen is very strict. We can't go away from the Pacific trial. It has to be given CCRT followed by in 42 days only. So, but at times we are not able to give within 42 days. Sometimes not only less than 65 are not there, more than in practical terms in real world, we have different kind of patient. So this real world trial was, French trial was done, the Pacific real world study which was done. And they had, this is included about the 1,399 patient, and median age was 66. That is, many majority of the patient less than 75, but many were more than 65, which was in the trial. And apart from that, stage were 14.3% patient received sequential, because at this age, sometimes it is not possible to give concurrent chemotherapy in elderly. And the starting time of durvalumab after CCRT was 56 days. So here still, because of late start, but what we find is the median PFS was similar to what the Pacific had. In fact, slightly better in this reported. We don't take it, but PFS is 12 months and PFS is 24 months. There was not difference between the two trials. So as far as a discontinuation is concerned, similarly, adverse event was seen in 60% and median time was 28. So, and main thing was, it was pneumonitis and ideal, which was moderate in 8.4% and severe in 2.9%. So what it says that no new adverse events were seen by delaying treatment also in elderly also. So all adverse events were comparable to the Pacific trial. Now this pneumonitis time to onset was 2.5 months and corticosteroid were required in 71.3% patient. So what this trial is showing that we may not stick to the inclusion criteria of Pacific only. It's a real world more than 65 years and age is there, and days if you have to give after 42 days also, there is no problem in giving durvalumab and results are similar. So this is the first and only approved immunotherapy to improve the OS and PFS in stage 3 in non-small cell lung cancer. And the difference in 5-year in median PFS was 31%. That is the improvement of 11.2 months in median PSF. And as far as OS was concerned, 47.5 versus 2.9%, with a 32% reduction in the overall risk of death, with a hazard of 0.68, which is very, very significant. And as far as safety and tolerability is concerned, we see 51% discontinuation, but because of pneumonitis, only 6.3%. So discontinuation rate are not high; they're quite less. And the most common adverse effect, of course, is the respiratory related, and few had a rash. So basically, what I'm trying to say is that this drug is very good as far as stage 3 lung cancer is concerned. I've been very happy with this drug, and somehow all my patients are doing very well in this drug. So in stage 3 lung cancer, if we have to go, we have to give a patient, if patient can afford it or patient is on panel, durvalumab is a standard of care at this moment, which included, and at this moment, there is no guideline to suggest that EGFR are to be taken out of this regimen. So with this, thank you very much. And I conclude my. Okay. Now, I think there are not many questions. If there are any, I'll be happy to answer. And if there are none, I proceed to the next topic. That is the optimal management of extensive stage small cell lung cancer, which is a case-based discussion. Now, this discussion will be taken by Dr. Somaiah Panda. He's alumni of Cancer Institute Adyar, and at this moment HOD Som Hospital Bhubaneswar, and kindly introduce your panelists also.
Thank you, sir. Such a wonderful talk again. And especially when clinicians share their experience on these molecules, then definitely it makes an impact on the usage. So with that, we'll move on to a small cell lung cancer, a dismal cancer, but many new hopes. I'll introduce my panelist. So I call upon Dr. Suresh Patel. He is a consultant medical oncology in Jalandhar, Capital Hospital Jalandhar. Dr. Ashwin Phillips, a colleague of mine, friend of mine. He is in CMC Ludhiana. And Dr. Deepak Bharti, consultant medical oncology from Department of Medical Oncology in Katra. And Dr. Priyanshu Chaudhary, he is a consultant medical oncologist in Mohali, Salvi Hospital, Mohali. So
I request all panelists kindly switch on your videos, please.
Survi, can you share my slides, please? So we'll move to a case-based small cell lung cancer discussion. Next slide, please. So this is a patient profile. He's a 62-year-old gentleman. He's a smoker and presents with increasing shortness of breath, hemoptysis, weight loss, and early satiety. And on examination, patient was found to have a massive liver enlargement. And on lab work, most of the parameters are okay, excepting the ALT and AST. And on the CT scan, it was found that there is a left lower lobe nodule, mediastinal lymph nodes are there, and there is a hepatomegaly. And a biopsy was done, which revealed a small cell lung cancer histology. So my first question will be to Dr. Priyanshu. Dr. Priyanshu, in small cell lung cancer, do you see some females are also there and non-smokers, or it is always smokers and male?
So I've never seen yet a non-smoker, sir. Although data suggests probably 3% would be non-smokers. But yes, I've seen a female who was a heavy BD smoker. But I've not seen yet a non-smoker small cell.
So Deepak, just a yes and no, because we see some females also and non-smoker also. So that's the reason I'm asking. Dr. Deepak, are you there? Dr. Deepak Bharti?
Yes, sir.
Yeah,
yes, sir,
so do you see females and non-smoker, or is it always a smoker?
So majority I have seen only smoker female only. I mean, that not seen any non-smoker female yet till my practice.
Okay. So Dr. Ashwin Phillips, I have a question that do you find that a biopsy or the approach to the tissue diagnosis in small cell, is it different from a non-small cell? Because the non-small cell usually will have a peripheral location. Small cell, mostly it will be mediastinal and central. So do you find any difference in approach or a biopsy part? Is it more of bronchoscopy or still we go ahead with the CT guide biopsy?
No. So like you said, sir, most of the small cells will have a hilar approach or a hilar lesion or a bronchial lesion. So it's more easier to do a bronchoscopic biopsy than going for a CT guided biopsy, fearing the risk of a pneumothorax and all the vessels nearby. So most of the time we do a bronchoscopic biopsy, unless of course it is difficult or the peripheral lesion or node is possible, which is easier to excise in biopsy. So most of the time it's a bronchoscopic biopsy depending on this situation or location.
Right. So the little bit of a difference in the biopsy is that more of it is central location. So it not be always easy for a biopsy. So Dr. Suresh Patel, I was asking that the PS, how is the patient PS? Is it different from a non-small cell?
Sir, generally small cell carcinoma patients have a poor PS because it is a more aggressive malignancy.
Yeah.
If you compare to non-small cell. And they generally present with advanced stage, extensive stage.
Right. So most of the patients in small cell, they are of an advanced stage and they have a central location. Many of them are not in a very good PS in SBCO. Unlike the clinical trials, take it any clinical trial in small cell which have included 0 to 1 PS, but unfortunately they are not extrapolated in the real world. Real world patients are a bit sick and they're very aggressive, fast moving. Even the patient, the tempo of the disease is such that by the time the patient comes, they're already in an advanced stage, unlike a non-small cell where they've got a prolonged ATT course sometimes, and they have been evaluated by orthopedicians sometimes for the bone lesions, but you don't find that in the small cell. So small cell is a bit of aggressive histology. So can we have the next slide, please? So we have discussed the diagnostic workup for the patient. We concluded that CT guide biopsy is always an option and a preferable option, but sometimes you don't get, then we'll go to the bronchoscopic. And if facility of EBUS is there, then definitely we'll go to the EBUS. And regarding staging, yeah, very important question for a small cell. So somebody who has done a PET CT, most of the centers, I believe that they have a PET CT now. So do you still go to the brain MRI? So quick answers from Dr. We'll start with Dr. Priyanshu and then we'll go to Dr. Deepak.
Yes, sir. Definitely.
Yeah. So in small cell, even if you do a PET CT scan and brain is screened to CT, still you would like to go to the brain MRI.
Yes, sir.
Any difference in opinion from Dr. Deepak or Ashwin or Dr. Suresh? Any difference in opinion, or you do compulsorily a brain MRI?
Yeah, the PET scan, the CT part of the PET is clear. Then still we will do an MRI, but make sure that you don't miss any other mets these patients.
Yeah. So sometimes the only precluding factor is that patient PS, which is sometimes difficult for the patient to lie down in a SBCO setting, or else if the condition of the patient permits, and definitely to go with a brain MRI. And sometimes MRI surveillance 3 monthly is also preferred sometimes if we are looking at avoiding a PCI. So we'll come to the PCI part later on. But the question to the answer is yes. So brain MRI in small cell, which has got a high propensity for spread to the brain, answer is yes. Can we move to the next slide, please? So this is the NCCN guidelines. So we have already discussed most of the things. Smoking cessation. So do all of your facilities have a smoking cessation clinics, or how do you go about? Because in extensive small cell lung cancer and small cell lung cancer, they do require a tobacco cessation clinic. So is it available in just a yes or no? I want to hear, because tobacco cessation clinic is really not present in most of the cancer hospitals, and trained cessation experts are not there. So Dr. Priyanshu and Dr. Deepak,
No, sir, not at my center.
Yeah,
No, sir.
Deepak, you have to unmute yourself, Deepak.
Sorry, sir. Regarding limited stage.
No, tobacco cessation clinic, is it there or not there? That much I want to hear.
No, not yet.
Ashwin?
On paper, yes, but practically no.
Yeah, you really have difficult. And Dr. Suresh Patel, do you have a tobacco cessation clinic in your hospital?
No, sir. No, sir.
Most of the centers accepting patients which have got very psycho-oncology clinics and cessation clinics, or else it is very, in big institutes you can have that. But routine cases, though it is a very important part of the treatment, we must remember, but we do face a difficulty in getting personnel for that, trained personnel for that. Next slide, please. So the patient was worked up, and patient underwent a biopsy. In the liver there was a mass liver confirmed with metastatic involvement, and brain MRI is normal. Patient was diagnosed with extensive stage small cell lung cancer with liver metastasis. So this was the finding from the biopsy and the imaging. So next slide, please. Now coming to the therapy. So we have diagnosed the extensive stage small cell lung cancer. Etoposide etoposide carborane. We will first complete that part. Dr. Suresh, can you hear me? Okay, we'll move to Dr. Ashwin.
Yes, sir. Sir, what was the question?
Yeah, Suresh, Dr. Suresh, tell me.
The patient is diagnosed with stage 4 small cell lung cancer, extensive stage. So my choice of therapy will be chemoimmunotherapy, atezolizumab plus etoposide.
No, Dr. Suresh, we are now discussing only etoposide cisplatin, etoposide carborane. Which one?
Okay. I generally prefer etoposide plus carboplatin based.
Any particular reason why?
Generally, tolerability is good, and Or in cisplatin, I generally recommend only for younger patients, those who are less than 65 years age. And I also go for audiometry before starting cisplatin based therapy.
Yeah, that's a
And
different.
one
So
more
in general,
component.
you reserve cisplatin. So I'll cut to that. In general, you reserve. You are worried about the dyslipidemia, the fluid overload
Yes.
in elderly, and that is the reason you are preferring a etoposide carboplatin. Ashwin, etoposide carboplatin or cisplatin?
So I would always prefer etoposide carboplatin, toxicity and the ease of giving it. I don't want to check the electrolytes, the fluids and all those things. So it's maybe a cisplatin is slightly more efficacious, but if you look at the total thing, it doesn't make much of a difference in a palliative setting.
Right. So, Dr. Deepak, etoposide carboplatin then AUC 5 or AUC 6, or most of the times it is very difficult, and you go to the AUC 4 and then see that patient is tolerating well, then hike it up.
No, sir. I am going with etocarbo with AAC 5. No 6.
Right. Right. So, Dr. Priyanshu, are you aware that instead of PEG-CSF, there are some newer molecules to look into? That CDK4/6 inhibitor has been tried as a growth factor in small cell lung cancer. Any thought on that?
Not that I'm aware of, sir.
Yeah. So these are some newer areas of research or interest that CDK4/6 inhibitor can be used in small cell lung cancer. Especially only for a growth factor kind of approach. So anyway, these are some preliminary research works in small cell lung cancer, but etoposide carboplatin, most of the centers prefer that, mainly because SBCO, fluid overload, dyslipidemia, and a brain metastasis. So you don't want the patient to be drowsy. So these are the reasons that we prefer going over the etocarbo. And number of cycles, 4 or 6.
Chemolon 6 with immuno 4.
Right. So, Dr. Ashwin, the Caspian data had both 4 and 6. So, in your center, it is 4, 6, or you look at the patient tolerance is tolerating well, I'll go ahead with 6.
No, so if it's the way, I agree with what Dr. Priyanshu said. If I'm only using chemo, then I want to get even though there's no survival benefit or any study showed the benefit of using 4 versus 6. But for all practical purposes, because it's a bad disease, in a practical sense, I will use 6 if there's no immuno. If there's immuno, then I stop at 4 and then see the response and take it up with immuno further.
Very correct. Very correct. So we are all worried that the moment we stop it, then disease might come back if we are not giving any maintenance. So I think that rationale is very well taken. Also, any other, Dr. Suresh, any other protocols that you use, irinotecan or any other regimens that you use, or we always prefer going ahead with etoposide platinum? You have to
Sir, in case of very old and poor PS patients, I generally go for irinotecan plus carboplatin, a weekly regimen also, in case of poor PS patients and fragile patients.
Right.
Weekly.
Right. So mostly we restricted to etoposide and platinum, and irinotecan. There is data for irinotecan and cisplatin, but none has been proven to be superior over the year, excepting that the toxicity part, when you are very concerned, that time you might choose as per your own experience. And regarding second line choice, we'll complete the second line here itself. Dr. Deepak, your second line choice, is it topotecan or something else?
If we are using immunotherapy up front, definitely we have to go for topotecan or temozolomide or Pecli. And if we are using only chemotherapy, then I will go for immunotherapy in second line.
Right. So any difference in opinion, Ashwin?
I would always, most of the time I've used topotecan only. So it's topotecan for me with or without immunotherapy.
Ashwin, topotecan availability is an issue for you, or it is?
We don't get the oral one. IV we are getting.
Right.
Oral we don't.
Correct. So Hicamtin is of limited supply, so we are not able to get the Hicamtin oral tablets, which the patients were easily getting earlier. So Dr. Priyanshu, anything new on the second line that you want to inform to the audience, or is it same irinotecan and topotecan or a paclitaxel? So there has been some data on trabectedin and even anthracycline plus means another trabectedin is lurbinectedin. Again newer, again a newer area. So these are some areas. So next slide, can we go to the next slide? So we have discussed that most of the panelists, they feel that right now in 2022 it is a etoposide plus platinum plus immunotherapy if finance is not an issue. Next slide. Correct. I think accepting finance part, any other concerns or a paraneoplastic, are you worried about the paraneoplastic? Anyone has an opinion on in which case you will not give a immunotherapy in present scenario? in a small cell lung cancer. So leave out the finance part. Anyone?
So somebody who requires a steroid for any probably any reason, might be some autoimmune disease or probably any paraneoplastic, whatever be the reason.
So when brain metastasis patients recurring dexamethasone, would you omit the IO, or you will still go ahead?
I would still use the IO. I mean, it all depends on whether you're giving radiation upfront or which is asymptomatic. So I would taper down your steroids to the minimum. Even if you look at the IO, if you were using Paclitaxel carbo, I mean, for those studies that IM power studies, they use Paclitaxel carbo. So they had to use a bit of steroids in those patients as well. So it's not that those low doses of steroids would make have no difference, but in the situation, if there was brain metastasis and after radiation, I have to taper the steroids. I wouldn't withhold the IO just because 8 mg DEXA is going on.
Right. So I think that it is an area where it is kind of a real unmet need. So the survival is really very bad in such a scenario. So yes, we'll taper down the steroids and try to continue the IO and push the IO wherever possible. So can we have the next slide, please? So these are the trials which failed to show the superiority of etoposide platinum and which made etoposide platinum as the first line setting in extensive disease. And then there were other two trials, landmark trials of atezolizumab and durvalumab. And atezolizumab both were almost showing at 12 months OS. And the first time it was reaching at 12 months. Earlier it was almost around 6 months to 8 months. So and both were approved, both atezolizumab and durvalumab. Pembrolizumab and nivolumab plus ipilimumab has been a failure. So Dr. Deepak, any particular rationale that you think of that why nivolumab and pembrolizumab has failed and why atezo and durvalumab has got an impact here?
So basically, the point is that till now, what you are saying about pembrolizumab, we have seen it is based on the biomarker study, right? PDL1, right? TPS or CPS. In this case, they have not taken care of it to that extent. That one point, and they have preset OS for significance level. They have not achieved that. But basically, if you see the 2 or 3 year data, it has shown improvement. But basically, the intention to treat population with pre-specified primary endpoint, they have not reached that. But if you see the results, if they follow the patient later on, they have shown significance after 2 or 3 years.
Yeah. So Dr. Suresh, any take on CTLA4? Because one of the arms in Caspian, we must remember that had a CTLA4. So any take on that, Dr. Suresh?
CTLA4 inhibitor, sir, generally for in small cell lung cancer patients, I do prefer chemotherapy over immunotherapy. So patients who receive chemotherapy, it is generally a chemosensitive tumor. So my take is, if affordability is not the concern, then I will go for chemoimmunotherapy, or else I am fine with chemotherapy also for small cell lung cancer.
Right. So the response to the chemotherapy issue is that it is very transient and temporary. They fail very fast. That is the reason that it's kind of a maintenance therapy with other. So we are discussing a scenario where we are not discussing the finance part. So that is the reason that Durval. So Dr. Ashwin, any take between the two, Durva and atezolizumab? Do you think any difference?
Both the trials actually showed a similar thing. The only thing is we can argue about it that there were brain metastasis, treated brain metastasis, not cisplatin used, not used, carboplatin was other arm. It all depends on what you're comfortable with. The main thing I feel is that immuno takes some time for it to act. So that's why the chemo plays a key role of debulking the disease. And so I've had a patient who's gone on to take some 20 cycles of atezolizumab maintenance. He came in a very bad shape. But the thing is that the chemo debulks the patient faster and the maintenance takes over after that. So I think the key is to give the chemo, and sometimes when we have a ECHS ESI patient on a scheme, it takes time to get the immuno approved. But waiting for the immuno to get approved can be a lethal thing. So you start the chemo, and it's between whatever you're comfortable with and what you can get easier. Durvalumab as well as atezolizumab, I think it's fair enough to use whatever your both of them are almost similar in every way actually.
Deepak, any difference in the between the, again I will ask you because this is a very valid question. We are discussing atezolizumab versus durvalumab and both are approved.
So basically there are two things regarding that. I am using durvalumab till now. I have 3 or 4 patients on chemo plus immuno, but I am using durva only. I have one patient referred from somewhere else who is on atezolizumab. Although he has done good, he has 6 to 8 cycle maintenance of atezolizumab on that. But point is that in durva, if you see, they have chosen very valid comparator arm with cisplatin and with 4 to 6 cycles of chemotherapy. Whereas in atezolizumab they have only using 4 cycles only. This is one point. Number 2 point, if you see the brain metastasis part, they are taken care of in Durva, not in atezolizumab. So if you have to choose one among the two, I think Durva has superseded the atezolizumab.
Right. So Dr. Priyanshu, any take on the brain mets part? I think Dr. Deepak Bharti brought out that point.
Yes, sir. It was a trial design. Atezo trial did not have patient, who had brain metastasis. They were probably excluded. And another is, I would say, if the maintenance part, the Durva maintenance is 4 weekly, you can use it. While Atezo, you have a 3 weekly probably. That, and in practice, sir, most of the thing is about availability, I would say. And in the panel, whichever is available, we prefer that. So I don't think so. Even the hazard ratios are pretty similar. I don't think those small things would make any difference.
Right. Dr. Suresh, any take on the 3-year data versus means a limited data for Atezo? Any take on that part? So are you more comfortable because of the 3 years, or it is equal as other panelists told that okay, it is the cornerstone is that Ito platinum plus IO?
Sir, I do agree with the data for 3-year survival with durvalumab. So durvalumab is better if you look compared to atezolizumab, because small cell lung cancer is an aggressive tumor and patients generally succumb to the disease very early. So the 3-year survival data for durvalumab should be considered significant, and I prefer durvalumab over atezolizumab for this reason also. And also in the study of durvalumab, they included patients with brain metastasis also. So definitely durvalumab is better compared to atezolizumab in the chemoimmunotherapy.
So,
for small
okay.
cell.
So Ashwin, any PD-L1, you will do any PD-L1? Both, if you look at the Pacific, you look at this small cell lung cancer data, Caspian, PD-L1. Any take on the PD-L1 part?
No, those studies didn't actually classify them as per the PD-L1. So the concept here is slightly more different than what you look in the standard lung cancers in these sort of diseases. So I really wouldn't do a PD-L1 or base my treatment based on the PD-L1.
Right. So even in the trial, both Atezo and Durva, PD-L1 is not a biomarker in small cell lung cancer. Dr. Deepak, tumor mutation burden or any hint that in which patient will you use more comfortably? Do you do a TMB or never?
No. I never do TMB, not in any solid cancer till now.
Right. So there are a lot of controversies coming to TMB. What should be the standard? And more so in SCLC, none of the IO have looked at the TMB as far as the data is concerned. So can we have the next slide?
Sir, I would like to add one thing.
Yeah,
So it is one of the highly mutagenic. I mean, the expression of new antigens in small cell is actually one of the highest if you see the graph. So probably that is one of the reasons that we don't need a PD-L1.
Definitely. So the chemotherapy produces more new antigens, and that is the rationale for the usage of the. Yeah, I agree to that part. But we have not yet found the correct biomarker. And give your best therapy in the front, because there is a rapid deterioration of the patient PS. Can we have the next slide, please? Coming to the guidelines, it has included both atezolizumab as well as durvalumab in your in the NCCN. And you can see that clearly durvalumab 159 milligram every 21 days, and then you can go out with every 28 days monthly is comfortable one. Next slide. So we have discussed the preference of the regimens, etoposide and carboplatin plus, and we have discussed about the real world data including both the cisplatin and carboplatin in the durvalumab. Next slide. So the criteria also we have discussed that part. Next slide. This part also we have discussed that. Coming to the PCI, a very important point. So Dr. Deepak, do you still practice a PCI, or from the IO era you have started practicing a PCI?
I'm just practicing the PCI only in limited stage, not in extensive stage till now. I'm not started yet.
So in extensive stage you are giving PCI or you are not giving PCI?
No, I'm not giving PCI. I'm just following the patient on this surveillance MRI or the PET-CT, whatever we are doing that.
Dr. Priyanshu, there is strong data that the patients are doing well with your chemotherapy. Then PCI does benefit as per the URTC trial. So any Japanese trial, you are following the Japanese trial, or you are avoiding the PCI, or what is your take?
Sir, first of all, I would like to say that in the era of immunotherapy, we don't know what is the exact role of PCI. So I'm following the Japanese protocol 3 monthly for the first year, then 6 monthly. And I'm using consolidative RT thoracic, but not PCI.
Right. So I think you have given two answers in one. Aswin, PCI, no PCI, thoracic RT, yes, no.
So the thing is, thoracic RT, no, along with the immunotherapy, because the studies, if you look at the atezolizumab study, they had allowed prophylactic PCI if the patient was in control. Thoracic RT was not allowed. So if the patient has a good response, age less than 60 is a criteria that we follow, for age less than 60 on all those things, and performance set is reasonably good. I'll discuss with the patient about giving PCI, but thoracic RT, no. Especially when I'm worried about immune-induced toxicities of pneumonitis and all those things. So probably no.
Right. Dr. Suresh, so in 2022, IO is there, and you don't want PCI, you don't want thoracic RT. What is your take?
Sir, I don't go for PCI and thoracic RT for extensive stage.
Right. So as in the as is the data, it is still a debatable and a gray area. Some patients they do prefer, but IO is there. After the IO, if there are hardly patient is asymptomatic, then better to continue with only IO and chemotherapy and then IO. So even upfront, if the patient is asymptomatic, still you can omit the PCI, means the radiation, and then continue, because systemic therapy is so important in this small cell lung cancer. Next slide, please. Next slide. So we have discussed this part that after 3 years data, it is something like tripling of the OS. So 5% becomes 15%, and that data is really good. Next slide. And as we discussed, the IMpower 133 and Caspian almost very close, 12.3 and 12.9. Next slide. And the we have already discussed that, but the 3-year OS in Atezo is not been reported, but it is something like more than 15% in Durvalumab. Next slide. So the patient is on Durvalumab 4-weekly maintenance therapy and serial scans are going on. Next slide. The PCI part we have discussed. Next slide. So as we have alluded, most of the panelists, they feel that PCI right now is a debatable controversial area, and they would like to avoid that, to avoid the cognitive decline and the side effect of the PCI, and the many of them are following the Japanese way. Next slide. So the PCI, there is a positive data, and that's the reason that it is still a debatable area. Next slide. Again, thoracic RT, we have discussed that patients responding, as well as the earlier the data was that patient responding well. If it is a partial response or a CR, then you consider the RT. But again, the data was that in the IO era, the AA is questionable, benefit is questionable. Next slide. Next slide. So this is the guidelines. If patients are having a complete response or a partial response and it is extensive stage, then PCI and thoracic RT is an option. But in PCI in the IO era, the patients they did well despite having a brain mets, and thoracic RT was also omitted. Next slide. This is the ESMO 2021 guidelines, which states that PS01 patients, if they are responding well, then you give itocarbo plus atezolizumab or durvalumab, and if patients are doing well, then continue the IO. Next slide. So the patient is on durvalumab maintenance therapy and is under surveillance imaging using brain MRI for metastasis. Next slide. So brain metastasis part, again we have discussed that part, that if the patient is asymptomatic brain mets, then you focus on the systemic therapy, and if the patient is symptomatic brain mets, then you can consider RT. Next slide. The same thing is there in the slide, that if the patient is having extensive stage with brain mets, symptomatic, give brain RT, asymptomatic, then preferably go for systemic. Next slide. And the brain metastasis part also we have discussed the choice of immunotherapy. Next slide. So with brain metastasis, without brain metastasis, it is almost like 13 months without brain metastasis and 12 months with brain metastasis. So it doesn't make much of a difference. It was significant in either of the arms. Next slide. So this is a subgroup analysis of IMpower 133. Brain metastasis placebo was better, and atezolizumab was not doing much compared to Caspian, which had a good effect even in brain metastasis. But the numbers are very small to make any conclusion. Next slide. So the patient is on durvalumab 4-weekly maintenance therapy and has completed 8 cycles of durvalumab with no evidence of progression. Next slide. And as mentioned by our panelists, that again, it is comfortable one that every 4 weekly the patient need to come and need not come every 3 weekly. And again, HHO has got different approvals for different doses. 2 weekly doses is also there. So that makes it very cumbersome for the patient to come again and again. Next slide. So PS part, we have discussed that most of the patients, they do come at a poor PS, and even in those settings, it is not a contraindication, though in the trial it was PS01, but hardly we see the real world patients of PS0 and 1 in small cell extensive stage small cell lung cancer. Next slide. So most of the patients, they are PS34 due to the tumor burden. Coming to the tumor mutational burden, PDL1, right now the data is really limited. Most of the clinicians, they are agreeing that they are not doing the thing. Next slide. So to summarize, first line durvalumab plus EP has shown a sustained improvement in OS, and it is in the real world practice, it has included both cisplatin and carboplatin, and benefit despite the brain metastasis, it was again there. Survival tripling is there after 3 years, and it is a convenient 1 monthly dosing, and that's the benefit of having a durvalumab in ahead of the atezolizumab. Next slide. So the new standard of care. With that, I thank all my panelists, Dr. Priyanshu, Dr. Deepak, Dr. Suresh, Dr. Ashwin. They have been wonderful and have been very interactive. Thank you, everyone. I hand it back to the organizer.
Thank you, sir.
Thank you, Dr. Panda. That was very crisp, and I mean, you covered all the various things which are important in treatment of extensive stage small cell cancer. And with this, we now come to the end of today's. This was a wonderful, and we had so much to learn from various aspects of BRAF mutation, and then we had a master class in EGFR mutated lung cancer from Dr. Navneet. Subsequently, we had bevacizumab. Generally not discussed in many of this discussion, and Dr. Jatin Sarin brought out very nicely. And finally, we had the extensive stage non-small cell lung cancer. So I thank all the participants who have actively participated to make it a grand success. And apart from that, I'll also like to thank the AstraZeneca team for bringing this meet together. And apart from Astra, I want to thank Tarun Mathur and his team for being, and apart from that, our sponsors, which are Reliance, Intas, Novartis, as well as AstraZeneca. So thank you very much, and back to organizer.
So good evening, and thank you very much for this words. And I think it's been a great show. The best part is very much well in time and a good academic fee. So from all of us, my colleagues Surbi and Geetika, good night, good evening, stay safe and stay blessed. With your permission, we close the meeting.